and get that going. Amazing. All right, so we'll get started. And today I just want to make another introduction in addition to last fortnight. We've got Dr. Matt Muir here with us today. Matt, and correct me if I've got your kind of bio a little bit wrong, Matt, but Matt's an integrative vet, so he's done a lot of qualification in both Eastern and Western herbal medicine. Is that right?
That's correct, yeah.
Yep, and a lot of experience in microbiomics, would you say? Is that fair?
I guess relative to most vets, probably yes.
Yeah.
I think in your email say expert, I'm not sure about that, but yeah, I did. I have done some field research work in microbiome, and certainly it's a special interest of mine. Yes.
Yeah. So Matt, in the sort of year or so I've been sort of working with Matt and co-managing cases with him, he sort of mentioned research he's doing at Sydney Uni and new food that he's helping develop, and so many different projects on the go in this field. And to just fully disclose conflicts of interest, we're going to talk a little bit about the food that Matt's associated with, or Matt's a founder of a food called Bicarb, which you might have seen advertised recently. I have nothing to do with this food at all, but I'm really excited, having sort of had the experience over the last year or so of dogs, particularly with IBD and reactive hepatitis, responding really well to dietary manipulation, and then getting into this subject that we're talking about today, to looking at the science behind it has been really exciting. So you want to give Bicarb a little bit of just sort of tell us what it's all about in 20 words or less?
It replicates what myself and most of the boarded nutritionists are delivering if people elect home prepared. So what we wanted to do was bring out a food that mimicked what most of the boarded nutritionists would do if someone elected home prepared. So our premise is that we have a higher protein, lower simple carb, more phytochemical rich vegetables enriched with omega-3, low omega-6 to 3 ratio as standard, following both AFCO and FEDIAF. So we just wanted people to have another option to try.
So like Matt said, it's essentially a home cooked diet for people that can't be bothered home cooking, which is excellent for people like me.
Yeah. And it solves the price a little bit too, because doing home prepared to the caliber that you'd want, it becomes generally cost prohibitive.
I guess when you can do it in bulk, there's an efficiency there for sure.
Yeah.
So I just wanted to disclose that conflict of interest, just so that people were aware that if they then saw Matt's face associated with this food, this is not a marketing meeting. I asked Matt to come really because I call him or email him when I've got cases that just aren't responding to traditional medical management, or that I feel could use some manipulation of microbiome. So I think he's an excellent resource. And actually the technical, what's it called, the document that you sent through?
Guidelines.
Yeah, is the most well-referenced kind of research on manipulation of the gastrointestinal microbiome that I've seen in a long time. So are we able to send that out to the attendees today, Matt?
Yeah, and I've actually just started pulling together like a deeper reference list of a lot of things that I've put towards our research proposal at Sydney Uni, and then just a broader reference list with regards to microbiome manipulation, microbiome and diet, and starting to look at microbiome and all of the other systemic downstream disease correlations that we're seeing.
Excellent. Okay, so what I wanted to start with, and obviously the main topic of today's conversation is going to be the host microbiome interactions. But what I wanted to start with is, I guess, an overview of the gastrointestinal tract and all of the different inputs that can impact gastrointestinal health. And I guess the point I want to get out of this first part is that there are so many factors impacting gastrointestinal function that you tend to sort of focus on the microbiome or infection or the diet. You kind of focus on one part of it, but there's so much crosstalk and interaction between all the systems in the body that are going to impact gastrointestinal function. So when we talk about gastrointestinal motility and function, can anyone just throw out some things that influence that?
Vagal nerve.
Yeah, excellent. So let's say CNS input, so neurological input to the gastrointestinal tract. There's the gastrointestinal nervous system, or enteric nervous system, is a nervous system that has as many cell bodies and axons in it as the central nervous system. It's such a complex nervous system, and most of it is almost autonomous. Like, it works just without input from the central nervous system, and it works by a combination of stimulatory and inhibitory interneurons. And we've covered neurological system recently when we talked about neurotransmitters. Do you guys remember what the excitatory neurotransmitters were in general? Josh's eyebrows just went really high.
That's got to be easy. I won't say anything.
Oh God, I can't remember. Sorry.
It's fine. The point is that most of them are actually different in the gastrointestinal tract. So it's a completely different nervous system that just kind of developed in parallel. So as an example, acetylcholine is one of them, excitatory. But then the nervous system has all of these sort of smaller chemicals. I shouldn't say smaller because that implies size, but chemicals that aren't as common throughout the nervous systems in the rest of the body, but that have both endocrine and paracrine effects. So some of the neurotransmitters we're going to sort of talk about are actually hormones or paracrine chemicals, which will have an impact on the local cells. Does everybody know what paracrine means? Or endocrine versus paracrine? Endocrine is a chemical that will impact function of a cell at a different location. So it's mobilized in the bloodstream. Paracrine is a chemical that's going to impact cells adjacent to or local to the cell that excreted it. So the gastrointestinal tract is a really important concept because most things produced in the gastrointestinal tract are only have a local effect, and we want to have the gastrointestinal tract pretty well walled off from the rest of the body. So the little chemicals that we sort of talk about as having paracrine or endocrine effect or being neurotransmitters are ones like somatostatin, serotonin, histamine, gastrin. What's the hormone that tells you you're hungry?
Ghrelin, isn't it?
Ghrelin. How do you remember that?
It's a funny word. I don't know.
When we did, gosh, I can't even remember what the topic was, but there's another medicine resident, Max, who attends every now and again, and he was saying, my tummy is ghrelin when he's hungry. And it's such a good way to remember it. So we'll just pass that one on. So all of those hormones that we sort of think have distant effects in the rest of the body are also having local effects in the gastrointestinal tract. So good. Sorry, I digressed a lot from nervous input, which would be vagal. What other nerves provide input on the gastrointestinal tract? That's a really hard question. Sorry. And it's probably more actually output from the gastrointestinal tract I'm thinking of.
Splenic.
Splenic, yeah, exactly. So there's these splenic nerves which are associated with the parasympathetic nervous system. Parasympathetic? I think they're actually sympathetic. But they go to the chemoreceptors and stretch receptors, and they're typically associated with danger responses in the gastrointestinal tract. So where vagal is associated with normal maintenance function, the splenic nerves are the ones that say, okay, there's a corn cob in my ileum. My proximal gastrointestinal tract is distended via the mechanoreceptors, detecting that stretch. I'm not going to eat So there's a central connection. I'm gonna show signs of pain and I'm not gonna eat. And that's the central connection. So it's not all just localized. There's a response to what's going on in the gastrointestinal tract. Okay, so that's nervous. What about the chemical environment? So why does the stomach differ from the intestinal tract?
So,
pH? Sorry.
Yeah, exactly. So we're going to have different luminal and mucosal factors which are going to impact the microbiomes that move through there, the state of the nutrients moving through there, and obviously the absorption and function of the gastrointestinal tract. So if you've got, for example, something that's osmotic moving through, like bile acid, for example, it's going to draw water into the bowel, which is then going to move through faster. And what comes out the other end is obviously going to be impacted by that. Okay, so we've got nervous input, we've got endocrine inputs, we've got chemical environment inputs, and I should say osmolality is another one in there as well. And then let's talk about the antigenic inputs. So what are the antigens that move through the bowel that the body has to either tolerate or respond to?
Like any dietary protein?
Yeah, absolutely.
Animal protein, plant protein. Is any bacteria as well?
Mm-hmm, absolutely.
mRNA and DNA.
Yeah, absolutely. We've mentioned bacteria. Tell me more microbiome components which impact.
It's probably one for Matt instead, I'd say, but do you mean more like your general commensal resident bacteria versus pathogenic bacteria, or?
No, I'm actually thinking outside of, so is the microbiome purely bacteria or are there other components to it?
Is the what, sorry? The
purely bacterial?
Oh, no. So it's like, I think it's a bunch of, it's like fungal, like archaic stuff, and
There's some old stuff, some new stuff.
Viral.
Good, excellent.
I guess are you also thinking about the mucin layer when you're thinking about antigens and neoantigens there?
So localization of those antigens, is that what you're implying?
Or more sort of getting into gut barrier integrity, or if we're not there yet, thinking more within the lumen outside, like beyond the mucin layer within the lumen, what else is going on there antigen wise? I guess. Sorry.
No, I was going to say that's a really good point. There are, and this was such a wake-up call for me, because you sort of do a fecal microbiome analysis and you sort of think, well, that's what's going on in the gut. But actually you've sampled the lumen from the rectum, what's going on in the rectum. You haven't sampled what's going on in the duodenum. And, logically, of course, that's going to be different from what's going on in the rectum. Yeah. So it's a really interesting point that there's the different antigenic stimulation or different antigenic impact on the gastrointestinal tract is going to differ at different levels of the intestinal tract. And then within that, it's not just luminal, it's in the mucin layer, and then it's in the actual epithelium itself. So there's a lot of intracellular parasites, cells, things going on which will impact the gut function.
Fortunately, it seems that it's emerging that in canines, there's more overlap between the mucin microbiome and the luminal microbiome compared with humans, because there's a bigger preponderance of Akkermansia and the sort of mucinophilic taxa in humans relative to dogs. So it seems like fecal microbiome is potentially of greater clinical utility in a canine versus a human because of this concern about what you're not seeing with what's sort of trapped up in the mucin layer.
Yeah. And is that true in health and in sickness?
Yeah, I think it's pretty early days in ascertaining that. It's more just that it seems like when you look at what is probably a core microbiota, which is kind of question with regards to taxa versus function, that it seems that there's more likelihood that the canine's more accurate, but I'm not quite across whether it depended on whether it's like a more eubiotic versus dysbiotic microbiome. But I would say it probably would be, but I wouldn't have the clarity to answer that. I guess the other thing with antigenic stimulation, are you also thinking about xenobiotics?
Yes, absolutely. What's a xenobiotic, Matt?
Foreign substance entering the body.
Good, excellent. And how would that have an impact on the gastrointestinal health?
Are you asking me?
Yeah. Or anyone can answer.
Well, I mean, it depends what it's doing. Like if it has other off-target effects that we don't know of, what it's doing to neurohormone, the cascade. There's a lot of endocrine disruptors. But if it's even things like, let's say, dogs are ingesting lots of storage mite, that potentially, like what's that doing there? So it's probably triggering a whole bunch of like segmented filamentous bacteria, SFBs, and all of the and triggering an inflammatory cascade, and also disrupting the microbiome. If it's anything that's got antimicrobial effects, it's potentially shifting the microbiome.
SFBs, sorry.
Yeah, so SFBs, segmented filamentous bacteria. I think that's me. When we're looking at the assemblage of the juvenile microbiome development and like avoiding dysmaturity, their bacteria, I'm not super good with details, so I like to kind of zoom out and look at it like a forest rather than going in like that, because I think that's actually the kind of ecology approach to this and the holistic approach. I think that's the way that it's good to understand. But going down into the detail, SFBs, I think, are they astral cells, or they I think they work with toll-like receptors to give like sensory input and package information to develop the degree of antigenicity that you'd get from the immune system. So they're reaching out, grabbing and sampling all of the things that are going past in the lumen to determine what they are and start sort of educating the immune system during immunomaturation. Yeah,
I think that's a really good segue. Does anybody want to go into the gut physiology any deeper before we kind of move on? Bearing in mind that the next topic is actually inflammatory bowel disease, so we are going to cover a lot of immunology in a fortnight. No one wants to go deeper into physiology? Weird.
I always like that.
Well, isn't it saying that the microbiome is an organ, so it is part of the physiology?
Absolutely, and that's why I wanted to talk about it in this, because we typically start a topic with physiology and then move on to kind of illness, and that's why we talk about this as part of the physiology discussion. So I think the main thing that the gut needs to do is absorb nutrients. It needs to move things through in a unidirectional manner. It needs to maintain its secretions, and it needs to talk to the central nervous system. Now, there's so many different things that can go wrong, and like Matt said, if you focus on one little element of it, you're going to miss the big picture. And I think there's a movement in human medicine to restoring balance in the gastrointestinal tract rather than focusing, we've focused so long on just the inflammation when we see pathology in the bowel, but we need to sort of take a step back and say, okay, what different manipulations might we be able to change? Should we change the pH in the stomach? Why not? Should we change the microbiome or try and manipulate the microbiome to minimize inflammation, or is that contraindicated in this situation and this dog just needs anti-inflammatory? So there's so many different considerations, and I don't think we're going to continue to evolve our understanding and change our treatments and recommendations with gut disease a lot in the next 20 years as the methods of analysing those different contributors to the forest emerge. Okay, so why don't we talk, kind of segueing from what Matt was saying with the immunology of the gastrointestinal tract, why don't we move on to what natural barriers are there for infection? What's the sort of innate immune response in the gastrointestinal tract?
I guess there's always, as Matt kind of mentioned, like the toll-like receptors, sampling constantly, trying to recognize foreign material, foreign things that can be stimulating that antigenic system to then start an inflammatory cascade to remove those. And it should be quite a small one relative to what the antigen is, I guess.
Yeah, absolutely. So you've gone straight to the top of the class, going straight to the most complex component of the innate immune system.
Oh, sorry.
No, it's great. I mean, this is so, just for context, anybody that doesn't know, Josh sat memberships last year. He was a medicine resident a year in. He's been working with us for the last 2 years. So I push him for more detailed answers often. But the things that, particularly people sitting memberships, don't forget the simple stuff. So if you had the contents of the gastrointestinal tract running through the bloodstream, what would happen?
Be pretty sick.
Yeah. So the physical barrier of the epithelium, the gastrointestinal epithelium, and the tight junctions between those cells are sort of part of the innate immunity. What else coats that epithelium, which minimizes kind of transfer of antigen between the lumen and the systemic systems?
Bicarbonate, like bicarbonate.
Bicarbonate, yeah. So that, yeah, absolutely. So that's a really good point. pH definitely controls microbial populations in different areas. So when we say, you sort of mentioned bicarb, and bicarb is the base that we sort of talk about, and hydrogen being the acid that we talk about. So in the stomach, what's the environment? Acidic or basic?
That's what I was going to mention.
Depends on what they eat.
The acid of the stomach is very antimicrobial.
Yeah, absolutely. Why? Sorry, you said
acidity, I guess, but not only antimicrobial, but anti just about anything nasty that comes in. It also helps protect the respiratory system, because we found that when we, shall we say, deacidify with drugs, that after a period in humans, like 9 months or so, they often get a secondary pneumonia.
Yeah. Interesting.
Yeah, and then alongside the acid, looking at like defensins, antimicrobial peptides, I think AMPs within the mucin layer that are being produced. I think that actually is in that review, looking at those secretins that act. That would be part of the innate system, because it's part of a mucosal barrier. Mucosal barrier function.
So innate just implies non-specific.
Yeah.
And with the gastrointestinal tract, is kind of the only place where the non-specific and specific sort of overlap. But so lactoferrin is another one. There's a produced by the bacteria or host, which will decrease the bacterial ability to bind and colonize an area in the bowel. And that's different along with different areas of the bowel for sure.
And used a lot in supplementation, but in some holistic circles. as a supplement.
Is it?
Yeah.
Lactoferrin, right.
Or gingival stomatitis in cats and probably dogs. But yeah, it's certainly, it's not something that I use a lot in my repertoire, but that's certainly interesting that you raise that it, from its endogenous, because I know it certainly has popularity around the world. So then with the adaptive versus innate kind of line blur, would natural killer cells fall into the innate side?
I have no idea. Sorry.
Versus like T1, T17, Treg, where would be more moving into adaptive in at the mucosal.
I reckon natural killer must be humoral. It must be adaptive. But the cytotoxic T cells still probably humoral. Anyway, sorry, we've gone a bit deep. I do want to go back to the pH impact, and I want to highlight the importance of the variation in environment in the bowel managing bacterial populations. So when you have fluid moving from the stomach into the proximal duodenum, it brings a wave of acid in. And so that actually is sort of population control of the bacteria of the proximal duodenum. Now, things moving from the stomach into the small intestine actually stimulates bicarb secretion. So you get this flood of bicarb in. So you go acid base, acid base, acid base as you're ingesting and moving things from the stomach into the small intestine. Now that fluctuation is really powerful population control in the proximal duodenum. So if you manipulate the pH in the stomach, or the ability to respond to, do we know what stimulates bicarb secretion in the gastrointestinal tract? I'm looking it up. Oh yes, okay. It's a hormone / paracrine chemical called, the name is kind of a hint. Starts with a, sorry, I'll just tell you. It's called secretin. Secretin, yeah. So when proteins and fats, I think, I just want to make sure, proteins and fats move from the stomach into the duodenum, secretin is produced by those local duodenal cells, goes to the pancreas and stimulates bicarb production, and also stimulates bicarb production in the bile. Now, concurrently, cholecystokinin is being produced because that stuff's moved from the stomach into the intestine, stimulating bile contraction. So all that bicarb that was just secreted into the bile is then ejected into the gastrointestinal tract to aid in digestion and increase the pH in the proximal duodenum. But that's, as we sort of said, manipulating the either proteins and fats moving from stomach to duodenum is going to impact your degree of secretion and cholecystokinin, or manipulating the pH in the stomach could have an impact on that. Excellent. So we've talked about the mucosal barrier. We've talked about the mucin and the chemicals. I say chemicals loosely, but you know what I mean, that decrease bacterial binding and colonization in different areas. What else decreases colonization of particularly pathogenic bacteria?
The host microbiome, like what already exists?
Exactly. So there's competition for binding sites, competition for nutrients. So the pathogenic bacteria find it hard to get a foothold because the microbiome is so well established in that area.
Mm-hmm. Secretory IgA.
Excellent. Yes, good. How does that work?
Well, does it not? I mean, I think it has multi-functions, but doesn't that like work for reducing binding potential and colonization? Absolutely,
and specifically targeted towards pathogenic bacteria. I shouldn't say pathogenic, but bacteria or molecules that the host has formed a response to. And that could actually not be pathogenic bacteria. It could be commensal bacteria or other antigens moving through. But IgA binds those, marking them for stimulating an immune response, inflammatory response. So do we know what happens with IgA in IBD? Increases, yeah, exactly. So we've got an increased host response stimulated by multifactorial, but evidenced by increases in IgA.
Which is, I think we talked about this in the past, to interject there with which what I find there's so much contradictory things with the microbiome, because say something like Saccharomyces boulardii, I remember we were talking about that for an IBD. I was like, well, it will increase IgA, and then we're like, well, why do we want to do that if that's already elevated? But then there's emerging evidence that VSL number 3 or Saccharomyces may have a role in abating and ameliorating IBD signs, and then looking at whether or not that involves even changes to the microbiome or not. So we're kind of potentially wanting to increase something that's already increased in a disease state, but seems to have some clinical efficacy.
And this is the problem with looking at the trees rather than the forest, isn't it?
Yeah.
Okay. So we've covered.
Sorry, the other one, I mean, talking about acidity, acid base, and the kind of acid flush into the small intestine, but then sort of beyond that, within the colon, we're wanting a rising acidity again as part of the innate immune system, particularly in the colon for things like salmonella, for example.
To increase or to minimize binding of salmonella, or
so increase short chain fatty acid production in the hindgut to make more acidic conditions to reduce the ability of pathobionts or pathogenic bacteria growing within the colon.
Interesting. I didn't know that. So what increases acid? So which trees should we be kind of watching for pH in the colon? Is it actually the luminal contents, like the short chain fatty acid?
Short chain fatty acid producing bacterial taxa, prebiotics.
Okay. So it's predominantly microbiome driven pH change.
Yeah.
Interesting.
That I know of. But I guess maybe probably when looking at that, it's probably what's modifiable, I guess. So dietary fiber, protein digestibility, I'm sure would have an impact.
Excellent.
And then the other thing with the increasing acidity, I've heard sort of mutterings about this, but I don't fully understand this aspect of it yet, but very fascinated personally in intermittent fasting, and where the dog should be eating once a day rather than 5 times a day, and what preparing the stomach for a meal. I heard someone say recently, like, to get that the gastric acid, the pH goes from 2 to 1 after 8 hours of fasting. So that's like the safest time if you wanted to do raw feeding or bone feeding.
Oh, right. Interesting.
To do it on an empty stomach and after a delayed fast, because actually that's when the body can neutralize the bacterial load or cope with, or like actually have the digestive capacity to handle a meal that would be considered indigestible. And I think that's sort of, I'll just touch on it briefly because I think it's not that relevant for this discussion, but people like say an ECC clinician's perspective of raw meaty bone feeding versus someone like in our clinic where many people would do it, not every dog, and there is a risk benefit. But if someone's fasting a dog or a dog that's used to a higher protein, lower carb ration and has a reduced gut acidity versus a dog that's on a more of a plant-based diet, like a 55% 55% carbohydrate diet, they're going to have different, I would say, different gastric acid dynamics. And so that if you fed a raw meaty bone to a dog that's doesn't have strong gastric acidity, or they don't have HCl, or they don't have the bile salts, then that's going to be more of a risk than another dog.
Yeah, right. I do want to go back and revisit what Josh raised with the TLRs and nods. And the one thing I want to flag here, Josh, that's an exactly right answer. But literally 10 years ago, when I was doing my fellowship, my residency training and things, this was not known. So there are people still reading versions of the textbook where TLRs and nods aren't mentioned at all. This is really new awareness that's coming out. So can you tell us what these pattern recognition receptors, nods, nucleotide oligomerization,
Deamination, is it?
Is it?
It's in this paper somewhere, actually.
I wrote it down somewhere, thinking I won't remember that. Nods, we'll call them nods. So can you tell us
Domain molecules.
Domain molecules. Okay, was that right? Nucleotide oligomerization.
Yeah, nucleotide binding oligomerization domain molecules.
Molecules. Okay, there we go. So can you tell us what they are, Josh?
Well, I think my understanding is quite basic, but my understanding is that they are just other sampling cells. So they're just trying to recognize or identify the difference between normal commensal bacteria and non-commensal bacteria. Is my thoughts, but
yeah,
quite basic.
You're exactly right in that they have a role in just, I guess, sampling the mucosal luminal bacteria. And I shouldn't say bacteria, like there's, they recognize viruses and different components of like protozoa and things like that as well. But essentially nods, TLRs are what we call pattern recognition receptors. And typically it's the humoral immune system or the adaptive immune system which facilitates having a specific response to a specific organism. So your body needs to have seen that organism before or have inherited maternal antibodies to it to respond to a specific organism in a specific way. Whereas in the gastrointestinal tract uniquely, there's these pattern recognition receptors where they're actually molecules typically inside of cells. And if a bacteria or virus gets into the cell, they recognize patterns on the surface of it to say, this is a gram-negative bacteria, I am a TLR4, toll-like receptor 4, and I recognize lipopolysaccharide. So I know this is a gram-negative bacteria, and I'm going to respond in the way that I respond to gram-negative bacteria that has invaded a cell. Same thing with nods. Typically, I think they're more specific for viruses, but again, they're inside the cell. So if you have a pathogen invading the cell, then they're going to mount an inflammatory response. So through intracellular signaling, they're going to then kind of facilitate an appropriate response to that organism being inside the cell. Now that's in health. Now what happens if we've got parvovirus and we've got mucosal damage and damage to the surface of these cells? How do you think that these receptors are going to respond to that? So typically they're inside the cell, they can't actually, they're not sort of responding to every single bacteria that's moving past. But when you get cell damage, those receptors then exposed to everything moving through the lumen.
Okay. So they become more hyperreactive.
Absolutely.
Yeah, okay.
Yeah, exactly. So it's not, parvo didn't cause all the inflammation. Parvo caused mucosal damage. And then the TLRs and nods and the rest of the immune system were exposed to way more antigens than they should have been exposed to. And we get this post-infectious inflammatory syndrome. This is really well reported in humans and really logical, but we haven't got studies that sort of document this specifically with viral infection in dogs or protozoal infection or any infection. But essentially mucosal damage, whether it's from food allergy or anything, is going to increase those pattern recognition receptors being exposed to luminal antigen and therefore responses. And then that applies to dietary antigen as well. So these receptors then stimulate an immune response, stimulate inflammation, and in situations where there is inflammation, those receptors actually get relocated to the surface of the cells. So the body almost ramps up that response and it primes itself to be able to respond more quickly and more accurately as those normal commensal antigens or pathogenic organisms move through the gastrointestinal tract. So they've got a huge role in both maintaining health, but also causing quite detrimental inflammatory responses to either dietary or microbiome antigenic stimulation.
On that point, looking at assemblage, and I think I'll send across afterwards, if you like, the dog risks, which is University of Helsinki, looking at a correlation with early diet and IBD risk, lifetime IBD risk. And then there's another one about early diet and atopic risk. But I think I'm sure I read somewhere that with regards to the dendritic cells and the macrophages and toll-like receptors learning, particularly from gram-negatives, that there's if they learn from LPS, from gram-negative bacteria, that if you use non-E. coli, depending on which, there's different LPSs that will either prime the immune system correctly, but if those bacteria are missing and the microbes there are more pathogenic, it will kind of start a process of immune tolerance or immune vigilance or hypervigilance, like what Josh said.
Can we define oral tolerance or immune tolerance, just for the record?
Well, it's more about what that if the body recognizes, so within a normal barrier integrity, without any issues barrier integrity, wouldn't it be that the immune system would recognize something as safe and release and not trigger a cytokine cascade that was pro-inflammatory versus anti-inflammatory, or neutral, I guess.
Exactly right. So it's tolerating antigens that would, in any other system of the body, cause a really immense inflammatory response. Within the gastrointestinal tract, there's huge amounts of antigen moving through there that the immune system just tolerates. And it's a really key concept, and was actually a fellowship question, define oral tolerance for me. So definitely worth kind of having that concept in the back of your head, that the immune system in the gastrointestinal tract has to be so advanced and is so delicately balanced given the amount of antigens that it's being told to tolerate or has to tolerate to maintain gastrointestinal function. Okay, let's move on to the more interesting stuff. Let's talk about how we can manipulate the microbiome. What impacts can we, how sort of therapeutically, what do we do that can impact the microbiome?
Practice antimicrobial stewardship.
Yeah, absolutely. Yeah. And appropriate use of antibiotics. And what's the most important component of that with regards to, if we've got a urinary tract infection and it's sensitive to amoxicillin and it's sensitive to amoxiclav and it's sensitive to enrofloxacin, which one are we going to choose?
Amoxicillin.
Yeah, exactly. So choosing the narrower spectrum antibiotic to minimize impact on microbial populations in the rest of the body, and obviously development of antibiotic resistance as a kind of One Health initiative. So certainly clinical interventions and illness. What illnesses might impact the microbiome?
enteropathogens?
Yeah, absolutely. Yeah. So gastrovirus is going to impact the microbiome massively. Why? Sorry.
How does the pathogen impact the native microbiome?
Yeah.
Well, it would trigger an immune response that would alter balance. It would outcompete sites, and it would potentially alter the gastric acid base balance by altering short chain fatty acid production, which would then potentially starve enterocytes of nutrients. So it could open the tight junctions and have systemic LPS increases. And which probably has a feedback loop to do something negative to the microbiome.
Well, that's like 150% answer just for anybody sitting memberships. Just that was a really good summary of all of the different impacts that gastrointestinal inflammation can impact health. The main thing I think, so if you've got an enteropathogen, it binds, causes inflammation, the change in transit time and motility, so either by ileus or by increased motility and diarrhea, we're going to be moving bacteria or allowing bacteria to multiply more quite kind of immensely. And talking about bacteria, also protozoa, fungi, all of the other organisms that fit into that ecosystem as well. We often change diet when there's gastroenteritis. So we're going to have different prebiotics and manipulation of the microbiome that way, which I guess comes to the next point. So certainly illness can impact the microbiome, but so can diet.
Just on the, can I just add a couple other sort of, I think, pathogenic sort of lines of inquiry that are sort of emerging and worth us being more mindful of is like endogenous nephrotoxins. So the gut renal axis is another one. So renal damage from indoles and p-cresol sulfates and other putretive factors in the colon. And what further to your point about ileus, I think with regards to the paralyzing, particularly around the pylorus, so like the migratory motor complex damage from bacterial endotoxins, then setting up a cascade of more of the kind of SIBO pattern, which I think this paper that you sent out, the 2018 paper, is sort of, I guess, SIBO, and correct me if I'm wrong from your perspective, but SIBO's kind of in veterinary gone out of the nomenclature, and it's more been replaced by dysbiosis as a whole. But to me, from my understanding, like they kept their, I mean, there's many, I think we'll learn that there's many different dysbioses and many peculiar microbial layouts, like a phobic one, an aggressive one, a carcinogenic one, like the whole bunch of different nephro damaging one. But with SIBO, I think certainly these infections then lead to bloating, delayed ileus, that then create a whole cascade of downstream or like chronic effects.
Yeah, absolutely.
In humans, it's the classic, like, you know, traveling around the world, getting food poisoning, and then having a functional GI disorder years down the track from and thought to be from paralyzing toxins in the intestine, causing a SIBO.
That's an interesting.
And then metabolic fatty liver disease. Sorry. Yeah. I
was actually going to say that sort of post-infectious that you mentioned, you know, getting gastro, like traveler's belly, and that then impacting the microbiome more permanently. Is that something that you've seen evidence of, like papers documenting permanent alteration of the microbiome? Because from this paper, it looks like it's actually quite stable and it's very little that impacts it long term.
Probably more clinical suspicion in clinic rather than evidence, but I'm sure I could probably dig something. Are you talking in canine feline or in?
I don't think we've got the evidence in canine feline, but certainly my understanding of that post-infectious inflammatory gastroenteropathy, my understanding was more it was that loss of tolerance because of exposure of luminal antigens to the kind of intracellular and submucosal immune systems, which would normally be protected from them.
Yeah, I think you'd have to decouple what management strategies were in place and what was actually potentially iatrogenic with what was continuing to happen. For example, like even outside of veterinary, like a low FODMAP diet for SIBO is supposed to be done as like a gastric rest, similar to, I guess, if we're talking about a hydrolyzed diet for 3 months for a dog with chronic enteropathy before reverting to a more complex diet that's not hydrolyzed, that if that hydrolyzed diet or the FODMAP diet was continued long term, then you might be putting one step forward, one step back, and actually not really getting anywhere and being in a state of chronic inflammation, perhaps.
Yeah, no, I can see how they kind of tie in together. And again, you sort of focus on the tree that you know, and then actually there's so many target effects.
What about, what about E. coli, E. coli and risk of IBD later, or in sclerosing, what's the feline?
Oh, FEGSFE, whatever it is.
You know what I'm talking about. There may be some footprints of E. coli colonization with that pathogenesis.
It's a really interesting, excuse me. And certainly there's a kind of school of thought that any autoimmune disease has a infectious trigger that we just haven't discovered yet.
Yeah, and in the human microbiome testing, like comprehensive GI mapping, they're looking at Klebsiella, certainly with sclerosing or ankylosing sclerosis of the lower spine, like in humans, Klebsiella has been, they monitor and grade some of these GI maps in humans, sort of say what someone's autoimmune risk is based on the dysbiosis that they find or elevated abundance of specific taxa. Yeah.
And that's evidenced in the kind of microbiome manipulations we can make and the impacts that they have, and not just the manipulations we can make, but also what we know of the sort of microbiome development. So in this paper, it talks about what happens if during the phase of development of the microbiome, the neonate doesn't get the normal kind of exposures. So say having antibiotics as a young, while that's developing, cesarean versus vaginal birth and different exposures of skin bacteria versus vaginal commensal organisms and things like that impacting that early microbiome development, and that predisposes to asthma, atopy, and there's MS is associated. Yeah.
Diabetes type 1 in humans.
Yeah, and metabolic syndrome in adults as well. So there's so many disease impacts that the microbiome is sort of responsible for. And when you sort of mentioned that autoimmune disease, I thought that was worth bringing up, that this sort of oral tolerance that develops early on, if that doesn't develop, then the immune system tends to be hyperreactive. And we've talked previously, I think, about Crohn's disease in humans not being a problem in third world countries where parasitic control isn't done routinely. So humans who get worms when they're young are less likely to get autoimmune bowel inflammation later in life. Did I explain that clearly? Yeah. So that's a really good example of you prime your immune system to tolerate a worm, and it's more likely to tolerate the commensal bacteria and everything else moving through later in life. It's less likely to mount an inappropriate response to those antigens. So that concept of oral tolerance is so important. And so when animals are young, and we're lacking evidence in dogs and cats, but it's very important. So let's talk about now.
Can I jump in there? Like there is evidence on this. It just doesn't get a lot of reading. But looking at dog risk in Sweden, in Finland, University of Helsinki, the dog risk project, they do a lot of more epidemiological work, but looking at all of this priming and downstream disease risk with they've identified correlations with cancer, IBD, atopy. Certainly mechanistically, there's still more to be elucidated, but that's sort of, they sort of focus heavily on, and they also look at transcriptomics, particularly looking at gut and then skin atopic transcriptomics. They focus a lot on atopy, IBD, which I think are good ones to be a very upstream disease process to look at versus waiting for more. Obviously, IBD is terrible, but more like the cancers and autoimmune disease down the track. Potentially with and when you talk about oral tolerance, an autoimmune tending microbiome, immune system, is T helper 1 to T helper 2 to 3 to 17 balance kind of something that you're looking at?
I've never measured the specific subsets of T cell populations as a kind of marker of autoimmune disease or tolerance. Haven't seen enough evidence to be able to draw conclusions from the results of that test, and therefore I wouldn't sort of pursue it. Have you seen?
No, more like when we're thinking like what is an overreactive immune system, we want the immune system to be finding cancer cells, viruses, bacteria that's beyond the gut, but we don't want them reacting to self. So I think naturopathically people talk a lot about T helper 1, T helper 2 balance, and kicking it from TH2 back to TH1 so that you get appropriate immunosurveillance. So true immunomodulation versus immunosuppression, where you're modulating the immune system to be in a more homeostatic balance where it's got the appropriate immune surveillance but not overreacting to chicken and red blood cells.
I like the theory. I don't think we've got the science.
Yeah.
We've only got a couple of minutes left, so I did want to just talk quickly about the use of probiotics and the merits of probiotic supplementation in manipulating the microbiome, and particularly in animals that have those conditions that have been associated with disruptions in this microbiome, and mostly gastrointestinal. There's lots of different types of probiotics, and we don't have a huge amount of evidence for the types that we're using clinically and the strain-specific sort of types that match with the papers. But I do think that this paper was interesting with that VSL number 3 that they mentioned, which is a combined multi-bacterial plus Saccharomyces supplement. Matt, can you describe quickly we did talk a little bit about Saccharomyces earlier, but combining a yeast as sort of competing for nutrients and binding with the bacteria can sometimes manipulate the immune system.
Yeah, using a combination of spore-forming and non-spore-forming bacteria have merit. One of the other big things logistically is survivability of the probiotic strains. Not that they need to be alive to work. You could, similar to that helminth thing, and going back to what you said about helminths, helminth therapy for Crohn's is an emerging modality once you have it. But even giving dead bacteria still potentially has a role. I don't think it should be routine, by the way, that therapy. But to me, Saccharomyces boulardii, particularly if there's a combination of antimicrobial administration and probiotics, then using a fungal probiotic or microbiotic has merit. But I do think that to me, it's probably more about survivability. using, like looking at the synergies between more of your bifido and lacto bacteria versus your Enterococcus faecium and Saccharomyces boulardii, I don't really see, I haven't had like a clear enough appreciation from the research to see exactly how they sort of synergistically work best. But I do know that it helps with survivability, and that Saccharomyces is they're affordable in a therapeutic dose. I'm looking at sort of 10 billion CFUs versus some of these probiotics. Really, that some of the board and nutritionists say you need 100 billion to enact change, which I don't quite agree with. But yeah, I think mostly multi-strain, higher doses is at this stage what most people in the space are sort of talking about. But if you wanted to use single agent, then I think Saccharomyces boulardii or Enterococcus faecium, or because VSL3 is not available in Australia to my knowledge yet.
We do have to wrap up, but I do just want to highlight, just as far as kind of our usual approaches to gastrointestinal disease, we usually reach for metronidazole, tylosin to manage these diseases, and sometimes they're necessary for sure. But there are other ways to manipulate the microbiome, and certainly choosing a probiotic, you know, if you're suspicious of what we would have traditionally called SIBO, for example, like a patient that has a very elevated folate level, and kind of particularly symptoms that localize to the proximal bowel, then manipulation of the microbiome might be preferential to an antibiotic as a first stage if they're not too unwell. And the other thing that's just emerging that I don't think we've got enough evidence to recommend, and it has to be kind of a last line, but fecal microbiome transplantation, which was mentioned in this paper. Now, this is an old paper. Given how quickly this field is emerging, this is a really old paper. There's a review that's just come out in vet clinics in North America, small animals, which I think everybody should read because it's a really nice summary. It's one of the core journals for internal medicine, and it covers a really nice kind of summary of the applications and benefits, potential benefits of fecal microbiome transplantation.
Is that the narrative review that's just come out on chronic inflammatory enteropathy?
No, it's specifically fecal microbiome.
Oh, right. Yeah. There's also a 2022 paper that's just come out. I'll send it to you afterwards if you want to discuss it. I think with FMT, I mean, we've been using FMT in clinic for 10 years, and we send to Texas A&M to get a dysbiosis index on the recip. We're very careful with our recip selection, even with regards to anxiety or breed malignancy risk, etc. It's definitely for refractory disease. So essentially a dog that can no longer handle immunosups or steroids, diet hasn't worked. So you're looking at food responsive enteropathy, your microbiome, your antibiotics, drugs, FMT, but sometimes I guess my key learning nowadays is that I look at microbiome restorative treatment, which is more of a holistic approach, and that looks at, because I think it's remiss to just flag, sorry, I'm hijacking your conclusion, prebiotics as well as probiotics. I think dietary fibers, prebiotics, your fat, your protein and fiber macro content of the diet, protein digestibility to avoid polypeptides getting into the hindgut to ferment, I think is another big one. But with FMT, if you haven't got a dog's the prebiotic strategy right before you do the FMT, there's a lot of prehab that you do on the gut before you put the FMT dose in. And so a lot of the time in clinic, we never have to get to doing an FMT, because if you do, you work through your polyphenols, prebiotics, get your diet right. You don't have to get to FMT.
Yeah.
We've used it for EGC in cats successfully too.
Eosinophilic granulomas complex? Yeah. Oh, interesting. We actually talked about that last week. That's really interesting.
Yeah, and I reckon it will have a role in other things. Yeah, no.
Yeah, we are going to do another IBD, so we can actually continue this conversation in a fortnight for particularly with the microbiome prebiotic, and we'll go a bit deeper into the immune system as well. Thank you so much, Matt, for joining us. That was excellent.
Well, thanks for letting me have a coffee and rant about things that I enjoy. I appreciate it.
Everybody loves the soapbox.
Yeah.
All right, thanks everybody for coming, and we'll see you in a fortnight. Any questions, let me know, and we'll send out a link to the recording and the papers that we talked about and the LICA technical guide as well. Thanks everybody. Speak to you soon.
Thank you. Thanks, Matt. Thanks, Anna.
Thank you.